and especially if we get it wrong or we sort of promise that something will happen and of course it doesn't, such as, you know, the huge HIV epidemic that was threatened, and arguably it's a lot better than it was because of public health measures. So life expectancy has been going up. You see a dip just after sort of 1600s, reflecting the sort of last wave of the Black Death, and there has been a gradual and quite impressive improvement in life expectancy since then. And again, it's this latter part that the technologists will be primarily focusing on and saying, look what medicine has achieved, when actually most of that achievement has been on the basis of public health. But I'm not bitter at all. However, the warning is, if you look at life expectancy in developing countries, from the mid-20th century, you saw an increase in life expectancy, which roughly matched what was happening in the rest of the world. You can see that Uganda started to fall off that trend really sort of after Idi Amin and general sort of social unrest. Other countries in Zimbabwe, Botswana, Kenya, South Africa have all seen quite dramatic decreases, all relating to HIV/AIDS. So we can't be blasé and say we have an expectation of forever having improvements in life expectancy, morbidity, mortality. We do have to be careful for this, which is why public health remains an important bedrock of our healthcare provision. But the main reason why we're in this sort of fifth golden age of public health is relating to smoking, drinking and alcohol, and obesity. And these are the major challenges that face us. So some of this data is actually quite scary from a public health, I suppose, and from a social science and political perspective. This is data asking young people aged 18 to 24 about what happened after the last time they went out drinking. So just the last time, not ever. And you can see that of those who were binge drinking, about 40% got involved in an argument, 10% or so got involved in a fight, 5% or so involved in having some broken, damaged, lost, 1 or 2% having something stolen, for example. And there's lots of other data. And if you start looking into this, you can also see interesting differences between the fact that females usually get into arguments, males usually get involved in fights, but I'm not going to get too involved in those sort of stereotypes. Looking at sort of hospital admissions in relation to alcohol, and over the last 15 years, you can see there have been some quite dramatic increases in the burden on the NHS from alcohol, in relation to hospital admissions, again, particularly in the younger age groups. And again, of even more great concern, you can see how sort of large numbers of deaths occurring from alcohol-related disease, particularly in the 50s and 60s. So if I was giving you a more of an epidemiology public health lecture around sort of alcohol, I can sort of talk a bit about more how also these trends are shifting. So you're seeing so the increasing alcohol problems amongst young people are going to start mapping across into more problems in terms of morbidity, hospital admissions, and you're going to start seeing the problems of deaths increasing and moving backwards in age. But alcohol is not it's not a new public health problem. Go back to the mid-18th century, particularly to this famous Hogarth photographs of Gin Alley. 6 times more gin was being produced in Britain at that time than beer. Gin was much cheaper. There were 15,000 drinking establishments in London. Half of these were gin shops, such that the government wanted to act. And so in 1736, the first Gin Act imposed prohibitively high duty on gin. Not surprisingly, the public didn't like it, and you can imagine the same way that we're not particularly keen at the moment on taxation on petrol. And we've already had a few years ago protests around that. Will we see them again? You know, this was what was happening in 18th century Britain. As a result, they started to reduce the duty, and it was fully removed in 1742. But the government changed tack. They had to find another solution. So in 1751, started to have a restriction to selling gin only on licensed premises. In the 19th century, again, more new tactics were coming into play, where licensing hours as well as licensing premises started to be restricted. And particularly during the First World War, there was the Defence of the Realm Act, where the first time started to introduce quite significant restrictions on when people can drink as a way of reducing the quantity of when they were drinking. And again, always tied into, just as with the Boer War, these things would have been tied into the First War and also into the Second World War. And only more recently have we started to see these restrictions and timing being removed, with 24-hour opening being possible from 2005. So what can we do about alcohol, and what is the government planning to do about alcohol? Well, I think the answer to that is to look what we've been doing in relation to tobacco, because largely we've been successful in relation to the public health challenge of tobacco, although there is still much to be done. So what have we done in relation to smoking? Well, we've tried to raise public awareness with media campaigns, health warnings on products, pricing and taxation, restrictions on advertising and merchandising by the industry, restrictions and regulations at point of sale, addressing antisocial behaviour by stopping people smoking in built-up premises and making them go out into cold and wet streets to smoke, and clinical treatment for patients with problems. And so we've learned from that in relation to alcohol by doing exactly the same thing, or attempting to do the same thing. So there have been drink-aware campaigns, not been successful thus far, but I think we'll see being much more aggressive with alcohol warnings on bottles and cans, etc. Pricing and taxation, I'll come on to that in a second. Advertising and merchandising, we'll see restrictions on. We already have obviously restrictions and regulations at point of sale, so going back to the 18th century. Addressing antisocial behaviour, an extremely important element of the government strategy in relation to alcohol, as well as providing clinical treatment for people who have alcohol dependence. So again, I could go into those things in great detail, but that would be a different type of talk. The main thing which is very topical at the moment and is very key to us in public health in terms of our strategy is the minimum pricing per unit of alcohol. But of course the message here is don't upset Middle England, and in many ways we had hoped from public health that it wouldn't upset Middle England, because on the whole some middle-aged people from Middle England, and of course being Welsh I would say Middle Wales as well, and Middle Scotland, Middle Northern Ireland, wouldn't really be going out and interested in binge drinking. They're not going to go to the supermarket and buy big crates of lager and tank themselves up before going out. I live in Headingley in Leeds, which is of student central in relation to the University of Leeds, and so if I go into the supermarket, which I try to avoid at all costs, on a Friday evening or Saturday evening, I am met by these waves of students coming out with their big special offers on Foster's and Carlsberg, etc. And really what's being proposed by the government is quite mealy-mouthed in many ways, because they're wanting to prevent alcohol being sold for its cost value, but actually not even proposing to do that. All they're proposing to say is you can't sell less than the cost of the tax and the VAT, and still doesn't build in the fact that it does cost money to build beer. So in many ways, if I was to go out and buy a bottle of wine, I'd be looking at £7, £8, £9 perhaps on a really good day. In a celebration, you'll go over £10, £15, etc. But these prices are not going to touch Middle England and the sort of alcohol that we might want to buy occasionally. But it's not really going to affect the students of Headingley either. So we may accept this in terms of what the government is proposing and just hope to try and ratchet this up step by step to start making a real impact on alcohol consumption. So I think let's reflect on where we are then in the sort of current period of public health. Increasingly, autonomy is the dominant concept underpinning the codes of conduct for health professional. And Nora O'Neill said a plausible reason for the triumph of autonomy is that there is one presently prized domain of life in which informed consent requirements are often seen not only as necessary, but also as sufficient for ethics justification, namely consumer choice. So there's a shift towards describing patients as consumers of healthcare, and healthcare being seen as a transaction covered by a contract, rather than a social good aimed at improving health to facilitate social flourishing. Now, we could make appeals to individuals to act altruistically in the interests of third parties, even though it is counter to their own interests. Individuals may be motivated to act in the interests of others out of a sense of solidarity, but consumerist approach in bioethics and public health ethics in particular cannot depend on making appeals to altruism or solidarity. And the problem we have is that consumers are unlikely to be receptive to arguments that personal sacrifice in the public interest is just the right thing to do, or even to accept the distinction between private and public interest is an artificial one, and as communitarians would argue, are one and the same. And instead the consumer is going to ask, what's in it for me? So, as Donna mentioned in my introduction, I was coordinator of a European project on public health ethics. And here's a couple of quotations from the empirical research we did with that, just asking people about, amongst various aspects of public health policy, we asked them about water fluoridation. So this was a Frenchman who said, they're not telling us why it's good, they want to make us rely more and more on their help. We don't have to think about anything anymore. Or a Danish woman, I just think it's a problem, doing this instead of getting involved at the root of the problem. There are some people who don't teach their children the danger of drugs or why you should brush your teeth, so we intervene. You're making a whole society of grown adults into people who can't sort things out for themselves. So this is the challenge that we have with public health. No longer can we take the view like of a Roman emperor and just say, oh, well, just stuff them. Let's just build an aqueduct there. And we're almost saying to the individuals, if you want your water supply, go and build your own aqueduct. And that's not going to work. So the implications for public health, well, yes, appeals to individuals to acquiesce to public policy that may not appear to be compatible with a direct or immediate private interest may not be effective. Individuals may feel good by acting at what appears to be altruism, but when designing messages for the public, policymakers need to ensure that citizens implicitly understanding what they'll be getting out of the policy in terms of their second-order preferences, save them having to pay tax in the long run. They would be similarly supported if that were to happen to them in the future, or to live in society compatible with their goals. And there's lots of other permutations of this. So, to start to summarise, hopefully I've shown that there are a series of these dark ages and golden ages, and the dates are put there of roughly are very approximate, and you'll see going through the various stages from Greece, Rome, Industrial Revolution, etc., etc. But these rises and fall in public health, golden age, dark ages, etc., have been triggered by a number of features. Scientific change, whether that be Hippocrates in the first golden age, or Robert Koch, Louis Pasteur in the fourth golden age, and arguably the fifth dark age in relation to the start to move into pharmaceutical approaches to health. Social change, the Industrial Revolution, leading to people like the Victorian social reformers saying, we have to do something here because society is falling apart. All governments needing a healthy workforce and military. Political change, the Roman Emperor falling, leading into the historical Dark Ages, or the French Revolution, and indeed the American Revolution and various other revolutions as well, making governments scared about social unrest because of the situation that the Industrial Revolution had put people into. And then economic change itself in relation to the pharmaceutical revolution, but economic change with the dominance of the pharmaceutical and the biotech industry. So the changes that public health can be mediated through environmental structural change with a population focus, particularly in ancient Greece, Rome, 19th century Victorian Britain, and possibly 20th century Britain.